Welcome to this session on tuberculosis, one of the world's most important infectious diseases. Despite being preventable and treatable, tuberculosis remains a leading cause of death from infectious disease globally, making this topic crucial for medical students. By the end of this session, you'll understand the general characteristics of genus Mycobacterium, distinguishing these unique bacteria from other pathogens, describe the morphology of Mycobacterium tuberculosis, understanding how its structure relates to its function and pathogenesis, list the virulence factors and their specific roles in causing pulmonary tuberculosis, identify the source and modes of transmission, comprehensive laboratory diagnoses of pulmonary tuberculosis, including microscopy, culture, and molecular methods, and understand principles of treatment including multi-drug therapy, and prevention and control strategies including vaccination and public health measures. Let's begin with a clinical case illustrating classic tuberculosis presentation. A 38-year-old woman presents to her primary care physician after returning from a 3-month trip to Jakarta, Indonesia, an area with high tuberculosis prevalence. She complains of chills and a cough that have persisted for the past 2 weeks. While cough is common, its persistence for 2 weeks warrants investigation for tuberculosis. The chills suggest systemic infection with intermittent fever. Her temperature is elevated at 38.7 degrees Celsius, indicating active infection. Importantly, her weight has decreased by 4 kilograms since her last visit 3 months ago. This significant weight loss is a cardinal feature of tuberculosis, earning it the historical name consumption, because patients appeared consumed by disease. Sputum was collected for culture and sensitivity testing, the standard diagnostic approach for suspected pulmonary tuberculosis. Multiple samples are typically needed for adequate sensitivity. Additionally, an ELISA assay reveals high levels of interferon gamma. This indicates a robust T helper 1-cell response characteristic of mycobacterial infections. Interferon gamma release assays are modern alternatives to tuberculin skin testing for detecting tuberculosis infection. The chest X-ray shows apical lesions in the lungs. Involvement of the lung apices is characteristic of post-primary or reactivation tuberculosis, distinguishing it from primary tuberculosis, which typically affects lower lobes. This constellation of findings like chronic cough, weight loss, fever, exposure history, elevated interferon gamma, and apical lung lesions strongly suggests pulmonary tuberculosis requiring immediate evaluation and treatment. Mycobacterium species possess unique characteristics distinguishing them from other bacteria. Understanding these features is essential for comprehending their pathogenesis and laboratory diagnosis. Mycobacteria are strictly aerobic organisms requiring oxygen for growth. This explains their predilection for well-oxygenated tissues like lung apices. They are acid-fast, meaning they bind phenol-based dyes like carbylfuran and resist decolorization by acid alcohol. This property, demonstrated by Zeil-Nielsen staining, is the hallmark of mycobacteria and the basis for rapid microscopic diagnosis. The acid fastness results from their unique lipid-rich cell walls. Mycobacteria are non-spore-forming and non-motile bacilli, appearing as straight or slightly curved rods under microscopy. While technically gram-positive based on cell wall structure, they don't stain well with gram stain due to their waxy cell wall preventing dye penetration. Special stains like Zeil-Nielsen or Auramine are required. They are catalase positive, producing the enzyme catalase that breaks down hydrogen peroxide. This characteristic helps in species identification. The unique cell walls are extremely lipid-rich, containing mycolic acids, complex waxes, and glycolipids. This unusual composition contributes to their survival in the harsh environment of phagolysosome within macrophages, resistance to drying, allowing airborne transmission, tolerance of extreme pH, and resistance to many chemical stresses and disinfectants. Most pathogenic mycobacteria are slow-growing, requiring weeks or months for visible growth. Important pathogens include M. tuberculosis causing human tuberculosis, M. bovis causing bovine tuberculosis transmissible to humans, and M. africanum endemic in parts of Africa. Tuberculosis is broadly classified into 2 categories, pulmonary and extrapulmonary. Pulmonary tuberculosis affects the lungs and is the most common and contagious form. It typically presents with chronic cough, hemoptysis, and chest radiograph abnormalities. Pulmonary TB is responsible for transmitting infection to others through respiratory droplets. Extrapulmonary tuberculosis affects organs outside the lungs and includes several important forms. Tuberculous meningitis affects the meninges covering the brain and spinal cord, causing headache, altered mental status, and cranial nerve palsies. This is the most severe form, with high mortality if untreated. Tuberculosis of the kidney or genitourinary TB causes sterile pyuria, hematuria, and can lead to kidney damage. Tuberculosis of bone, particularly affecting the spine called Pott's disease, causes vertebral collapse and neurological complications. Tuberculosis of skin, or cutaneous TB, presents as various skin lesions, including lupus vulgaris. Tuberculous salpingitis affects the fallopian tubes, causing pelvic pain and infertility. Tuberculous intestine or gastrointestinal TB occurs from swallowing infected sputum or consuming contaminated milk, causing abdominal pain and intestinal obstruction. Extrapulmonary TB is more common in immunocompromised patients, particularly those with HIV, and often results from hematogenous dissemination. Tuberculosis cell wall components collectively contribute to virulence. The entire lipid-rich structure resists host defenses and many antibiotics. Mycolic acids are long-chain fatty acids that resist phagocytic digestion. These waxy lipids form an impermeable barrier, protecting bacteria from digestive enzymes and reactive oxygen species in phagolysosomes. Sulfatides are sulfolipids that prevent phagocyte activation and inhibit phagosome-lysosome fusion. By preventing fusion, bacteria avoid exposure to lysosomal enzymes that would destroy them. Trehalostimycolate, also called cord factor because it causes bacteria to grow in serpentine cords, inhibits phagocyte chemotaxis, preventing immune cell recruitment, prevents phagocyte activation, blocks phagosome-lysosome fusion, and inhibits digestion within phagocytes. It's one of the most important virulence factors. Lipoarabinomannan, or LAM, is a complex glycolipid that prevents phagocyte activation and enables bacterial survival within phagocytes by interfering with signaling pathways. Mycosides are glycolipids that prevent intracellular killing and digestion by neutralizing reactive oxygen species. Importantly, cell wall antigens induce delayed type hypersensitivity, or DTH, which is the basis of the tuberculin skin test. This DTH response contributes both to protective immunity and to tissue damage, seen in active tuberculosis. The source of infection is infected persons whose sputum contains acid-fast bacilli. Individuals with active pulmonary or laryngeal tuberculosis are the primary sources. Not all infected individuals are equally contagious. Those with smear-positive sputum containing high bacterial loads are most infectious. Cavitary lung disease is particularly contagious because cavities contain massive bacterial populations. The primary mode of transmission is person to person, by inhalation of respiratory aerosols. When infected individuals cough, sneeze, speak, or sing, they generate droplet nuclei. These particles are small enough to remain suspended in air for hours and reach the alveoli when inhaled. Transmission occurs through airborne droplet nuclei from an active tuberculosis case. Close, prolonged contact in poorly ventilated spaces increases transmission risk. Brief casual contact rarely transmits infection. Less commonly, transmission occurs through ingestion of unpasteurized milk from cattle infected with M. bovis, causing primarily gastrointestinal tuberculosis. This route is rare in developed countries with pasteurized milk. Several risk factors increase susceptibility. The elderly have waning immunity. Malnourished persons have impaired immune function. Socioeconomically disadvantaged people face crowded living conditions and limited healthcare access. Most importantly, immunodeficient patients, particularly those with HIV/AIDS, face dramatically increased risk of developing active tuberculosis after infection. Primary infection represents the first encounter with M. tuberculosis, typically occurring in childhood or first exposure. The initial infection characteristically occurs in the lower lobe of the lung, often in the mid-lung zones, because these areas receive the most airflow. The primary infection creates an exudative lesion with inflammatory reaction. Neutrophils initially respond, followed by macrophages. Giant cells form, created by fusion of epithelioid macrophages, surrounded by a zone of epithelioid cells, activated macrophages with abundant cytoplasm. A tubercle forms, which is a granuloma containing bacteria, with characteristic enlargement of draining hilar and mediastinal lymph nodes. This combination of peripheral lung lesion plus enlarged lymph nodes is called the Gone complex, visible on chest X-ray. From the primary focus, bacteria can spread by direct extension to adjacent lung tissue, lymphatic spread to regional lymph nodes and beyond, or hematogenous spread through bloodstream to distant organs. Hematogenous dissemination can cause miliary TB, widespread small nodules throughout lungs and other organs resembling millet seeds, a life-threatening form requiring immediate treatment. Secondary infection represents reactivation tuberculosis, typically occurring in the lung apices. This develops in the upper lobes because oxygen tension is highest there, favoring aerobic mycobacteria. Secondary infection is characterized by granulomatous lesions with extensive tissue destruction, cavity formation, and high bacterial loads, making it highly contagious. This diagram illustrates the complex pathogenesis of pulmonary tuberculosis from initial infection through granuloma formation and potential outcomes. The process begins when aerosols containing mycobacteria are inhaled and reach the alveoli. Alveolar macrophages, the lung's resident immune cells, immediately engulf the bacteria through phagocytosis, attempting to destroy them. However, mycobacteria possess virulence factors, allowing them to survive and replicate freely inside macrophages rather than being destroyed. The infected macrophages secrete cytokines including IL-12 and TNF-alpha, signaling danger and recruiting additional immune cells. These cytokines increase localized inflammation, with recruitment of T cells and NK cells to the infection site. IL-12 particularly induces T cell differentiation into Th1 cells, which subsequently secrete interferon gamma or IFN gamma. IFN gamma has two critical functions. First, it activates infected macrophages, enhancing their antimicrobial capabilities. Second, it strengthens phagosome-lysosome fusion, helping macrophages digest intracellular bacteria. Activated macrophages develop enhanced killing capacity. TNF-alpha enhances intracellular killing by stimulating production of nitric oxide and reactive nitrogen intermediates, which are toxic to mycobacteria. This explains why patients with decreased IFN gamma or TNF-alpha production or receptor defects face increased risk for severe mycobacterial infections. The diagram shows granuloma formation, where alveolar macrophages, epithelioid cells, and Langhans giant cells containing intracellular mycobacteria form the central core of a necrotic mass surrounded by a dense wall of macrophages and various T cells. This structure contains infection, but also causes tissue damage. The immune response to tuberculosis determines whether infection is controlled or progresses to active disease. Th1 response, representing cell-mediated immunity and inflammatory responses, is required to limit disease and provide protection. This is the protective immune response involving activated macrophages and cytotoxic T cells that control bacterial replication. In contrast, Th2 response, representing humoral immunity with antibody production, provides no protection against tuberculosis. Antibodies cannot access intracellular bacteria hiding within macrophages. This explains why vaccines stimulating cell-mediated immunity are necessary. Immune status is very crucial in determining tuberculosis outcomes. Immunocompetent individuals usually control infection, while immunocompromised patients, particularly those with HIV, frequently develop progressive disease. Interferon gamma from CD4 T cells activates macrophages to kill intracellular mycobacteria through enhanced phagosome-lysosome fusion and production of reactive oxygen and nitrogen species. CD8 lymphocytes become effective in killing mycobacterial infected cells through cytotoxic mechanisms, releasing bacteria into extracellular space where they're more vulnerable to immune attack. Interestingly, exposure to environmental mycobacteria provides some cross-protection that may limit disease caused by virulent species. This occurs because environmental mycobacteria share antigens with M. tuberculosis, priming the immune system. However, this cross-reactivity complicates tuberculin skin testing, potentially causing false positive results in individuals exposed to environmental mycobacteria or BCG-vaccinated persons. In a granulomatous reaction, a fibrin layer develops around the granuloma through fibrosis, further walling off the lesion. This encapsulation contains infection, but also creates a hypoxic environment where bacteria become dormant rather than replicating actively. Typical progression in pulmonary tuberculosis involves three characteristic processes. Caseation refers to the cheese-like necrotic material in granuloma centers, resulting from tissue death and incomplete bacterial digestion. This caseous material contains large numbers of dormant bacteria. Calcification occurs as healed primary lesions mineralize with calcium deposits. These calcifications leave scars appearing as opaque spots on chest radiographs, visible as gone lesions or calcified lymph nodes. Cavity formation represents a critical development in secondary tuberculosis. As caseous material liquefies and drains through bronchi, it leaves cavities, hollow spaces in lung tissue. Cavity walls contain massive bacterial populations with access to oxygen, promoting bacterial replication. When cavity contents are coughed out, patients become highly contagious, and the bacteria can spread to other lung areas, causing extensive disease. The balance between bacterial proliferation and immune containment determines outcomes. If few bacteria are present and few macrophages are stimulated, small granulomas form and bacteria are destroyed with minimal tissue damage. If many bacteria are present, large necrotic or caseous granulomas develop and become encapsulated with fibrin. This effectively protects bacteria from macrophage killing, allowing dormancy. Bacteria can remain dormant in this stage for years or decades, potentially reactivating when immunity wanes due to aging, malnutrition, immunosuppressive therapy, or HIV infection. In primary tuberculosis, patients are typically asymptomatic or have minimal symptoms, which is why primary infection is often only recognized through tuberculin skin test conversion or incidental chest radiograph findings. However, active pulmonary tuberculosis causes characteristic symptoms. Fever is present but typically low-grade, often with characteristic evening rise in temperature, distinguishing it from other infections causing sustained high fever. Constitutional symptoms include fatigue, weakness, and weight loss, which can be profound. The weight loss is insidious, occurring over weeks to months. Night sweats are classic. Patients awaken drenched in sweat, requiring clothing changes. Respiratory symptoms center on chronic cough, defined as cough persisting more than 2 to 3 weeks. Initially dry, the cough becomes productive of purulent or blood-tinged sputum. Hemoptysis, coughing up blood, occurs from erosion of blood vessels in cavities and is an alarming symptom, prompting medical attention. Physical examination findings are often minimal early in disease. Weight loss may be evident. Lymphadenopathy, particularly cervical, may be present. Chest examination may reveal dullness to percussion over affected areas. Decreased or absent breath sounds occur if pleural effusion is present. Crackles may be heard over involved lung areas. Tuberculosis in HIV/AIDS patients shows different patterns. Some remain asymptomatic, but others show rapid progression to active disease. There's a higher rate of reactivation of latent infection. Extrapulmonary and disseminated disease are more common. Chest radiographs may appear atypical without classic upper lobe cavities. Laboratory diagnosis of tuberculosis uses multiple complementary methods, each with specific advantages and limitations. Specimen collection is critical. For pulmonary tuberculosis, sputum is the primary specimen. 3 early morning sputum samples on consecutive days provide optimal sensitivity. For children unable to expectorate, bronchial aspirate or gastric aspiration collected first thing in morning can recover swallowed sputum. All specimens require specific decontamination procedures to eliminate contaminating bacteria and concentration procedures to increase bacterial density for detection. Direct microscopy provides rapid, presumptive diagnosis within hours. Acid-fast staining using Zeil-Nielsen or ZN method visualizes red-stained mycobacteria against blue background. Auramine stain, visualized by fluorescence microscopy, allows faster screening as fluorescent bacteria are easier to spot. However, microscopy requires relatively high bacterial loads, approximately 10,000 organisms per milliliter, limiting sensitivity in postbacillary disease. Culture remains the gold standard, providing definitive diagnosis and allowing drug susceptibility testing. LJ medium is traditional, but growth requires 2 to 6 weeks due to mycobacteria's slow generation time. Middlebrook agar or broth are alternative media. BACTEC rapid culture systems using liquid media and automated detection reduce time to 1 to 3 weeks. Molecular methods using PCR detect bacterial nucleic acid directly from sputum, providing rapid, sensitive, specific diagnosis within hours. Newer platforms like GeneXpert MTB/RIF simultaneously detect M. tuberculosis and rifampin resistance. Anti-TB drug susceptibility tests are essential given rising drug resistance, determining which antibiotics will be effective. The tuberculin skin test, also called MAN2 test or PPD test, detects tuberculosis infection by measuring delayed type hypersensitivity responses. The test involves intradermal injection of purified protein derivative or PPD, which contains antigens from M. tuberculosis. In individuals previously exposed to M. tuberculosis or vaccinated with BCG, these antigens trigger delayed type hypersensitivity responses. A positive reaction shows induration, a palpable, raised, hardened area, measuring greater than 15 millimeters in diameter for healthy adults. The measurement is read 48 to 72 hours after PPD injection. Importantly, induration, not erythema or redness, is measured, as redness alone doesn't indicate positive reaction. The tuberculin skin test represents a type 4 hypersensitivity reaction mediated by memory T cells. When PPD is injected, memory T cells recognizing mycobacterial antigens are recruited to the site, releasing cytokines that cause local inflammation and induration. Skin test reactivity usually develops 3 to 4 weeks after infection, the time required for cell-mediated immunity to develop. Tests performed during this window period may be falsely negative. False negative results may occur in several situations. Very recent infection before immunity develops gives negative results. Anergic individuals, especially HIV-infected patients with low CD4 counts, cannot mount DTH responses. Older people in whom DTH responses have waned may have false negatives despite previous infection. False positive results occur in individuals vaccinated with BCG vaccine, which contains live attenuated M. bovis. BCG vaccination causes positive tuberculin tests, complicating interpretation in vaccinated populations. Additionally, exposure to environmental mycobacteria can cause positive reactions. Treatment uses multi-drug therapy administered through directly observed therapy, or DOT, where healthcare workers watch patients swallow medications. This ensures adherence and prevents drug resistance from incomplete treatment. First-line drugs include isoniazid, or INH, which inhibits mycolic acid synthesis in bacterial cell walls. Rifampin, or RIF, inhibits bacterial RNA polymerase. Ethambutol, or EMB, inhibits cell wall synthesis. Pyrazinamide, or PZA, is particularly effective against dormant bacteria in acidic environments. Standard treatment involves an intensive phase using all 4 drugs daily for 2 months, followed by a continuation phase using INH and RIF for 4 more months, totaling 6 months for drug-susceptible tuberculosis. This prolonged therapy is necessary to eliminate all bacteria, including dormant organisms, and prevent relapse. Prevention strategies are multifaceted. BCG vaccine, containing live attenuated M. bovis, is given in countries with high tuberculosis burden. While BCG doesn't prevent infection, it reduces severe disease and meningitis in children. However, BCG efficacy against pulmonary tuberculosis in adults is variable. Health education about covering coughs, completing treatment, and recognizing symptoms enables early diagnosis and treatment, interrupting transmission. Contact tracing identifies exposed individuals requiring evaluation. Treating latent tuberculosis infection prevents progression to active disease. Infection control in healthcare settings prevents nosocomial transmission. Addressing social determinants including poverty, malnutrition, and overcrowding reduces tuberculosis burden. The emergence of drug-resistant tuberculosis represents one of the greatest threats to tuberculosis control, requiring urgent attention and new strategies. Multi-drug-resistant tuberculosis, abbreviated MDR-TB, is defined as resistance to at least isoniazid and rifampin, the 2 most effective first-line drugs, with or without resistance to other anti-tuberculosis drugs. MDR-TB typically results from inadequate treatment, patient non-adherence, or transmission of resistant strains. Treatment of MDR-TB requires second-line drugs including fluoroquinolones and injectable agents. These drugs are more toxic, more expensive, less effective than first-line drugs, and require treatment for 18 to 24 months. Despite prolonged treatment, cure rates for MDR-TB are only 50 to 70%. Extensively drug-resistant tuberculosis, abbreviated XDR-TB, represents even more concerning resistance. XDR-TB is defined as resistance to isoniazid and rifampin, plus resistance to any fluoroquinolone, and resistance to at least one of 3 injectable second-line drugs, including amikacin, capreomycin, or kanamycin. XDR-TB has extremely limited treatment options. Cure rates are very low, often below 30%. Treatment requires using drugs with significant toxicity and uncertain efficacy for 2 years or more. Drug-resistant tuberculosis emerges through several mechanisms: inadequate treatment regimens, patient non-adherence to therapy, healthcare system failures, and transmission of resistant strains. Preventing drug resistance requires directly observed therapy, ensuring adherence, proper drug combinations and durations, treating latent infection, and rapid diagnosis of resistant cases to implement appropriate therapy and prevent transmission.